Hi, I'm Sarah Hooper, and I'm a lawyer, an advocate for health equity, and a granddaughter. I was home for Thanksgiving just a few weeks ago and went to see my grandmother. I walked in the door to her home, smelled a turkey roasting in the oven, and heard the bright chatter of dozens of family members who had also come to see her. She greeted me with a big smile, her hunched shoulders bird-like in her yellow sweater, her cane rooted firmly in the ground, propping her up. And as I stoop down to hug her, I'm pretty sure she still knows who I am. And I feel grateful in that moment that her dementia hasn't taken this from us yet. Dementia is a painful disease. And I don't want to give you the impression that every day of my grandmother's life is roast turkeys and rooms full of family. It's not. But still, when I think of her, surrounded by our family in her home in which she raised her children, I think, what privilege. Because the next week, when I return home to walk to my office in the heart of San Francisco's Tenderloin neighborhood, I pass several people sleeping on the street, as I usually do. One of them is an elderly man who sleeps lying flat on his back. His shoulders, bird-like, peek out above a blanket, and his face is upturned to the traffic and noise of the city's morning commute. He looks like he has surrendered, and the day is only just beginning. Why is this man spending the last years of his life on the street, surrounded by traffic, while my grandmother is aging in her home? For generations, we have told ourselves that it is because of the choices they have made throughout their lifetimes. We've reassured ourselves that we can ignore the sick and the poor among us because they have simply failed to make the right choices. But what we as students of health equity, as leaders, know is that these disparities exist because of the choices we all have made. Especially in the richest country in the world, we have health disparities because we choose them. We've been writing my grandmother's story and this man's story through a million choices we make about who can access education that leads to good jobs, that provide access to healthcare, and the means to retire in safe housing, and the dignity to age on one's own terms. It's not an accident that my grandmother and grandfather were able to purchase a home in a mostly white neighborhood in a safe part of town, that they had access to middle-class jobs that mostly covered the bills for a large family, that their children could choose to live and stay nearby and were not displaced by gentrification or floods from a broken levee, that they have safety net health insurance provided by their state when the cost of their care overwhelms their retirement savings. It's not an accident that in San Francisco, a city with unimaginable wealth and technology, more than 50% of individuals using homeless shelters are over the age of 50. And it's not an accident that our health and social service systems are still not designed for people who are elderly, have mental illness, are homeless, or all three. We make these choices in the actions that we take or don't take. And as a society, we are all responsible for them. I'm often the only lawyer in a room full of health professionals, and for many years have felt a little bit sheepish about being at the table. After all, what does a lawyer know about making people healthy? We're usually more known for making health providers feel a little sick. But Over the course of my career thus far, and particularly in this fellowship, I've come to believe that the project of health equity is at its heart a test of democracy and a product of social justice. Health is not possible without a healthy civil society in which all of us have a voice in the millions of choices we make in a democracy that create the conditions for healthy lives. Over the course of our work together in this fellowship, we have learned about the importance of engaging communities in producing and safeguarding health equity. This is a democratic endeavor. It is the belief that collective action and collective decision-making can produce systems that work for everyone and result in health for all. But here's the thing. Democracies only work when we have faith in them and in our ability in ourselves that we can make a difference. Faith that all voices will be heard and counted and belong at the table. Which is why I've come to appreciate that the project of health equity does not uniquely belong to medicine or law, public health, economics, or any other discipline. It belongs to all of us. And more importantly, it belongs as much to the man lying in the street in San Francisco as it does to my grandmother, as it does to you and me. We can only achieve justice together, and the process of obtaining it matters. I was reflecting on this over the last week, the importance of process. I think this is something we understand intuitively when we start our work, but then forget as we acquire more knowledge, power, acceptance, and success. When we first started building my organization, I was about a year out from law school. I was a baby lawyer surrounded by towering figures in medicine, law, and science. I couldn't believe my luck in getting to work with these people and entered every room expecting to be called out as a fraud for being there. But I believed deeply in what we were doing, and I thought that even though I didn't have as much to tell these towering figures, the thing I could do was listen. It occurred to me that in order to build an interprofessional program, listening to others and learning from them might just be key. So I met with as many people as I could. I drove to medical clinics in all corners of San Francisco and met with providers. I walked down to the probate court and met with judges and investigators there. I talked to our law faculty and administration. I talked to our students. I talked to legal aid lawyers and nonprofits in the community. And I realized that they weren't talking to each other, but that if they did, we could make radical change together in our community. So we started bringing people together and did something that at the time was a little crazy. We were in the depths of a massive recession. Budgets were being slashed and programs cut, and many were concerned for the very future of our law school. But in that environment, we started a new clinic, a medical legal partnership for older adults in our community. And this program quickly gained state and national attention. And I started to have opportunities to share this model with others. I felt deeply that this model could help more people if others adopted it. And so I eagerly accepted any and all invitations to teach, guest lecture, be a panelist. And at some point, I was spending more of my time telling than listening. So then a little over a year ago, I was working on a sustainability plan. I wanted to not just sustain our program, but develop a business and policy case that would justify its expansion. I wanted to show that providing older adults with access to civil justice as part of healthcare was not only the morally right thing to do, but also the smart thing to do. And I thought, I need a study to show the impact of our program. What problems can't be solved by a 5-year NIH grant and a publication? So I started working on a proposal. I talked to colleagues about research design, and I spent hours reading the literature, developing complex theories about our impact and logic models. And then I saw the announcement for this fellowship. I thought, this can help me develop a better proposal. I'll have access to more literature, and I'll talk to people who are really good at doing this and how they've advanced their programs. And I was privileged enough to be chosen and to join you all. We met that first week nervously, each of us waiting for someone else to call us out as frauds for being here, right? And then something important happened. Over the course of those 2 weeks, I learned about a framework for leadership that resonated with me deeply, but I had not considered in such terms before. I was a community organizer. And my job was to activate the power and agency in others so we could make our common aim. And I realized that to do that, I needed to return to listening. I hadn't really listened to our people in some time. And I realized that before we could talk to others about the impact of our model, we needed to understand what it meant to us. So I asked team members about their experiences, their values, their successes, their frustrations, and I learned a lot. I learned from our social worker what it meant to have a lawyer as a partner in her clinic. I learned from her that when our teams worked together to address social determinants of health, patients got to leave the hospital sooner than they otherwise would have. They got to go home. I learned that when we work together, we can resolve barriers that have frustrated both patients and providers for years. I learned that this was a huge burden off of her shoulders, not to mention what it meant to patients and caregivers. And what's more, I learned that it was a relief to the health system. It turns out that our social worker understood better than anyone how reducing this burden on her also saved the health system money. When we looked at our data together, patient outcomes and legal outcomes, we realized we had saved the hospital $800,000 from helping just 5 patients. This was enough to pay for our program many times over and allow us to advocate for hundreds of other older adults with complex medical and social needs. And there it was. After all my time on my own spent developing theories and logic models, the policy and business case was there the whole time in the lived experience of our team. And all I needed to do was ask and to listen. So what have I learned? 5-year NIH studies are unnecessary. No, I'm kidding. I'm kidding. Of course, those things are critically important, and they will continue to be in our program and so many other programs. But what I've learned is that as leaders for health equity, our goal is not to be better at generating data or landing that next grant or winning that next case. Those things are necessary, yes, but they are still too often about us as individuals, working in our silos, and not about us working together or with our communities. Our goal as leaders for health equity is to listen, to take that knowledge and be connectors, organizers, and mobilizers, to see the big picture, to engage others, and bring everyone to the table. And especially to make sure that every single person in our community, from our colleagues across disciplines to our neighbors living on the street, know that their voices and their lives not only matter, but are critical to the success of this project of health equity. And if we can do that, we can ensure that living, growing, and aging in health and with dignity is not a privilege, but a right made reality for us all. Thank you.